Well, while we're getting my slides pulled up, I'd like to just introduce myself quickly. My name is Nosheen Reza. I'm a fellow in advanced heart failure and transplant cardiology at Penn. So what does that mean? So that means I'm already a cardiologist, did that training, did all the tests, passed, and now I'm getting extra. Yeah, it's important to know that I passed. Thank you. I appreciate it. A lot of money sunk into those tests, let me tell you. And now I'm doing extra training in advanced heart failure and transplantation, some of these concepts you've heard about already. And I'm doing extra special training with Dr. Owens, Dr. Day, and the rest of the Penn inherited cardiac disease team here, so I can be like them when I grow up. So I'm here to talk to you a little bit more about medical and surgical management. We'll talk a little bit more in depth about some of the concepts you heard about this morning from the other physicians, and sort of drill down into the nitty-gritty of each disease specifics. And my goal is to really sort of help you share our language, tell you when we say these medical words, what are we talking about, help you understand what your symptoms mean in the doctor vocabulary, and how you can sort of bridge those two worlds, help you understand when we're asking you to get all these tests and labs, like what is that for, what does that mean? So hopefully I'll accomplish that in the next 20 minutes. If I don't, please feel free to tell me and ask questions. If I can figure out how to do this. There we go. So you've seen this diagram from Dr. Owens this morning, so I'm just going to focus on the medications, device, and surgery. And as we've been talking about all day, the different types of cardiomyopathies, I'll spend the most time just with HCM at the beginning, just to walk you through each of the medicines and the testing, because you'll see it come up again and again as we talk about DCM, non-compaction, and arrhythmogenic cardiomyopathy. So here's my outline. Like I said, I want to help you recognize the symptoms and disease presentation. What are the goals of medical management, the timing for device implantation and surgery, if that's appropriate for you, and the timing for referral for heart transplant. And of course, this is a talk sort of based on the presence of symptoms. And like we have sort of mentioned earlier, not everyone has symptoms. And you heard from Dr. Owens that some people in the same family, directly related to each other, have completely different disease presentation, so I just want to acknowledge that, but we'll be talking about symptomatic folks here in this talk. So HCM, as we've discussed this morning already, is when the heart becomes thickened, and here's a diagram there on your left. You can see the middle area of that left ventricle, and sort of all around that pink area is the muscle, and it's become thick compared to the normal one seen on the left. And sort of we'll be talking about the different chambers and areas of the heart. Mostly what we're going to be talking about is this left ventricle. That's the sort of abnormality that you'll see in sort of all the pictures. So here you can see the left ventricle has a thick pink muscle wall. The inside space where the blood flows is smaller than the one you can see in the normal heart. And so when this happens, you can get the symptoms I'm talking about there on the right. So when you have trouble breathing, especially during exercise, we're going to ask you about that. And what we say is dyspnea. You've probably heard that word already this morning. Trouble breathing that gets worse when you lie down and better if you stand up or sit up. We call that orthopnea. Chest pain we'll ask you about, and especially ask you about if it gets worse with activity or better with rest. We'll ask you if you're feeling faint or like you're going to pass out, or have you passed out. We call that pre-syncope and syncope. And feeling if your heart is skipping beats, we're asking you about palpitations. And if you have swelling in the legs or the feet or the ankles, we call that edema. And so this is sort of the run-through that you'll get. Every time you especially see one of us in the cardiomyopathy team, a lot of your other doctors on the care team, they'll be concerned about asking you about these symptoms. So I know it can feel really, everybody's asking me the same stuff over and over again. But this is what we're trying to get at. These are the key symptoms for us to recognize at what stage your disease is in. So if you have these symptoms, like we mentioned, trouble breathing, chest discomfort, feeling faint, fatigue, skipped heartbeats, swelling in your belly or legs, this is what your doctors are thinking. Is there an obstruction to the blood flow leaving your heart caused by that thick muscle in your heart? Are you progressing to heart failure? And sort of differentiating the two. Heart failure we're using in this capacity to mean that your heart can't pump the blood as strongly as it used to anymore. Or are you having abnormal heart rhythms that are going to put you at risk for having something else go on? And we'll talk a little bit about what those are. And so here are cartoons of all the tests that many of you have probably already had, or are coming up soon in your medical care. So we'll just start at the top. So that's a picture of a gentleman undergoing an electrocardiogram or getting an EKG. So every time you come see us, you'll get an EKG. We keep track of them. We compare every one that you've had. And again, we hear people say, I just had one of these. Why are we getting another one? It's very important to us to sort of track how the electrical system of your heart is doing and to see if you're having any abnormal heart rhythms or abnormal heart beats. Right below the gentleman getting an EKG is the gentleman getting an echocardiogram or an ultrasound of your heart. And that is basically just like any other medical ultrasound you've probably heard of. We specifically look at the heart and the surrounding structures. It helps us get an understanding of the size of the heart, the structure of the heart, how thick those walls of the heart are, and how well your heart is pumping. So it's a very important test for us, and we'll repeat it a lot, a year, 2 years. Depending on sort of which cardiomyopathy you have, will sort of dictate that, how frequently you get one. We'll also sometimes and often put you on a treadmill. You can see a picture of a treadmill there, and then do the same thing. We'll ask you to exercise and then also repeat an echocardiogram. We want to see how you're doing not only when you're laying down there at rest, but also how your heart is functioning when you're exercising. At the top right, you can see a gentleman sort of wearing like a man purse. That's actually a Holter monitor we're going to use in this setting, or it's an event monitor, it's a cardiac monitor. In our clinic, we're trying to move to sort of a patch monitor that you just, like a sticky, that you can just stick on your chest instead of sort of wearing all of the leads and this satchel. But they're all basically the same, and the goal for them is to record your heartbeats. So again, we sort of talked about before, if we're worried that you're having skipped heartbeats or you're having a sensation of palpitations or lightheadedness or dizziness, that's what we're thinking. And so the test to evaluate that is the monitor. So usually we'll have you wear one anywhere from 24 hours, 48 hours. We're sort of leaning towards longer term monitors now. We'll order a 2-week monitor, and we'll try to make it as sort of less invasive and less bothersome as possible. So especially with the sticky ones that you can just sort of stick on your chest, wear underneath your clothes, go about your normal business. When the 2 weeks is up, you just take it off and then mail it back to the office, and we interpret it and take it from there. And then on the bottom left, that's a cartoon of a lady getting an MRI. So again, you saw some pictures of an MRI this morning with different cardiomyopathies. That is, again, to look at the structure and the function of your heart. And you might be wondering, well, you just told me that the echocardiogram does that. I did, you're right. But they give us 2 different kinds of information. So what we can get from the MRI is a bit different than what we can get from the heart. And for some reasons, some people can't have MRI. So we sort of use the combination of tests to get the best sense of the heart's function and structure. So that's why we do the MRI. And again, it may be a test that for your specific cardiomyopathy, you may be getting more than once if there's something specific that we need to look at. And then on the bottom right, that's a picture of a cartoon of a catheter. So if you are someone that we're worried about with the heart is sort of not pumping as well as it used to, if there's something else we need to measure, there's a procedure called a cardiac catheterization where we would like to measure the pressures inside your heart. So you'll actually come as an outpatient to the hospital, have this procedure done. It's not under general anesthesia or anything. You're sort of lightly sedated, and we just put a catheter into a vein, usually in the neck. It lasts anywhere from total prep time to being done with the procedure. Your whole visit is probably something like 3 to 4 hours from beginning to end before you're walking out the door. But it gives us a lot of information about how your heart is pumping and how we need to tailor your treatments if what we're doing we're on target with. So what are our treatment goals? So again, we have our list of symptoms there. The goals are to relax your heart muscle, to slow down your heart rate, to keep you hydrated as appropriate for you, decrease the abnormal heartbeats if you're having them, and then, as we've sort of briefly mentioned before, if you're someone who's having trouble with fluid retention, we give you a diuretic as needed, and that's very important, specifically for HCM patients. So just to review and sort of categorize these medicines for you, some of you may be on them or have family members on them. There's a class of medicines we sort of use as the first line. These are beta blockers. These are helpful to relax the heart muscle and slow down the heart rate. These are medicines like metoprolol and atenolol, and I've just put in parentheses their brand names there because you may have heard them referred to as both. We also use calcium channel blockers like diltiazem and verapamil for this purpose, again, to relax the heart muscles, slow down the heart rate. And Norpace, or disopyramide, it's technically in the category of an antiarrhythmic, but again, we use it in the capacity for HCM to, again, relax the heart muscles, slow down the heart rate. So this is sort of the upfront medicines that we'll have HCM folks on if they're symptomatic. Here's a water bottle to remind you to stay hydrated. It's something specifically for HCM patients. We'll ask you to keep an eye on, stay hydrated. Don't let yourself get dehydrated. Keep a water bottle with you. Keep track of how much you're taking in every day. And then diuretics, which do the opposite, help you get rid of fluid if you're somebody that is holding on to fluid. These are medicines like Lasix or furosemide, Bumex, bumetanide, or torsemide. So if you have symptoms despite these medicines, the Band-Aid plus the pills, we're still worried that you have blood flow obstruction. And so how do we sort of get at that? So that's when we start talking about what Dr. Owens had mentioned before, septal ablation or surgery. So 2 different procedures. Your sort of eligibility or candidacy for both is really made on an individualized basis. It really depends on which area of the heart is thickened in your specific case, how symptomatic you are, what your response to the medications have been up to that point, and if you have appropriate, essentially, anatomy to be able to do one of these procedures successfully. So even if you have a thick septum right in the middle where we think an ablation would work, not everybody has a blood vessel going to that exact area, so not making it possible for everyone. These are all things that we look at before we make these decisions. And then, of course, we take into account the rest of your general health. If you have any other medical problems that we need to be concerned about, balancing the risks of each of these procedures. And then I mentioned briefly the abnormal heart rhythm. So some of these examples of them are atrial fibrillation, atrial flutter, which you may have heard about. These are abnormal rhythms that involve the top 2 chambers of the heart, or ventricular tachycardia or sudden cardiac death, which you've heard about a little bit earlier today. Those are abnormal rhythms that involve the bottom chambers of the heart. So if you're somebody that we're worried about having those, if we found some of those on that cardiac monitor that I mentioned before, then we'll start talking about pacemakers or defibrillators, again, concepts you've heard about this morning. And that's a conversation we'll have with your cardiomyopathy team, an electrophysiologist as well. And then some folks can also undergo an arrhythmia ablation, which is a procedure in which the electrophysiologist will try to target the area of the heart that is causing the abnormal heart rhythm and then try to do a procedure to get rid of it, essentially either burning or freezing the heart tissue that's acting up and causing a problem. Again, these are all this is like a 30,000-foot view. Each of the decision about which arrhythmia you're having and what procedure or what medicine is best for you, that's a decision made by you and your cardiology team. So what if you have symptoms and you're on medicines and you still have symptoms, but you're not a candidate for septal ablation or myectomy, and your heart pumping is getting weaker? And the way that we sort of quantify this is a decrease in your ejection fraction, a word you may have talked about or your other doctors ask you about, a good number to keep in mind. This is when we sort of start the referral for a heart transplantation process. We've heard a little bit about this earlier. There's a cartoon of your kidney and liver just to remind us that we're always thinking about all of your organs, and we're worried about if all of your organs are getting enough blood flow. So when we ask you to get labs, not only at this stage, but also when we're seeing you and you're otherwise doing well, we're always watching out for the kidneys and the liver and the blood counts and sort of everything else going on in the body. We're taking care of everything. So we're going to move on to DCM, but a lot of these concepts are going to be the same. So you'll see a lot of the same pictures, a lot of the same sort of workup and evaluation. So I just wanted to make that point again. So here we have a picture of a heart that's dilated. You can see again, we're focusing on the left ventricle there. You can see that it's enlarged. And as a result, the left ventricle in these scenarios doesn't pump the blood out as well. And so you can have a lot of the same symptoms. Again, we have the trouble breathing, the edema, the fainting we'll ask about, the skipping heartbeats we'll ask about. We'll also ask you if you're having decreased ability to exert yourself. So we'll ask you, do you do your normal activities? Can you shop for yourself? Can you go up and down the stairs in your house by yourself? Or do you need help now? Have those things changed? And sort of, again, do you have sudden shortness of breath at night that's waking you up? Another question that we'll ask about. How many pillows are you sleeping on? And that's an important key question for us as well. So again, sort of same framework. You can have no symptoms, or you can have any of the symptoms we talked about. And what we're worried about, again, is the heart pumping function getting weaker? Are you having heart failure in the sense that the blood can't leave and get out of the heart to go to the rest of the body? Or are you having any of those abnormal heart rhythms we talked about again? And you can see the workup is the same. So again, as I mentioned, the echo, EKG, the monitor, the cardiac monitor your heartbeats, putting you on a treadmill, seeing if you can exert yourself and how far you can go before you get symptoms, a cardiac catheterization if it's appropriate and needed, and sometimes an MRI. And again, so you have the symptoms here, and our treatment goals here are a little bit different. You'll see a few different meds, but you may have heard of the ones that we've already talked about earlier this morning. So to decrease the work of the heart and slow down the heart rate, again, we are using these beta blockers, metoprolol, carvedilol, bisoprolol, to help the blood flow throughout the rest of the body and to help sort of stop the changes of the heart and possibly in some cases reverse those changes. We're using the medicines you heard about earlier, ACE inhibitors. So those are the ones that end in pril, lisinopril, enalapril, benazepril, and so on. A cousin of those, the angiotensin receptor blockers, the ones we were talking about earlier, losartan, valsartan, they end in sartan. And the newer drug that we were talking about earlier, again, Entresto or sacubitril valsartan. So those are all there to help your heart pump blood to the rest of the body and sort of stop or reverse the changes in the heart. And you can see at the bottom, there's a couple of other medicines we use to help blood flow in situations if you can't take these other two medicines or other three medicine classes up there. But we really try to focus on the ACE inhibitors, angiotensin blockers, and the Entresto class. And then we have to keep your fluid in balance. And usually people with DCM have a harder time with retaining fluid, and so they often need more diuretics than what we talked about with the HCM population. So again, you can see the diuretics there. So, and Dr. Owens mentioned that beta blockers and the class of ACE inhibitors, angiotensin receptor blockers, and Entresto, the green check marks here means they save your life. So there's a reason we want to keep you on them. This is a reason why we ask you if any other doctor tries to change these medicines, call us before that happens. Don't let anyone touch your cardiac medicines without letting us know, because we know that these are helpful for you in the sense that they will save your life and help and stop your heart from sort of progressing down the spectrum of getting worse. So very important to us. So again, something similar, sort of you can have the same abnormal heart rhythms with DCM. And I just want to specifically mention, folks, that if you know, some of you maybe in this room, that you have a mutation or variant in lamin AC, which can also cause muscular problems, or filament C, a newer gene we're learning more and more about. We know that folks with these mutations, they have sort of abnormal heart rhythm sort of out of proportion to maybe how weak the heart is. So for a lot of other people with DCM, we sort of wait until the heart gets weak to a certain cutoff before we'll consider needing a defibrillator for prevention. But for these folks, we consider it really early, because we know that these folks are at higher risk to have abnormal heart rhythms even before the heart gets weak. So we'll start having the conversation about defibrillator and pacemaker and ablation if needed earlier with these folks. And this list may grow. I'm sure if we do this conference in 5 or 10 years, this list of genes may be bigger than it is now. And again, sort of similar to before, if you're still having symptoms on medicines, but your heart is getting weaker, this is when we start talking about the referral for heart transplant or a ventricular assist device. DCM is the population where we're using more ventricular assist device just by nature of the structure of the heart, what's going on for the heart. If we have any questions about that, we can certainly talk about it at the end. Moving on to non-compaction. This is just a picture of a non-compacted heart. You heard a little bit about the causes and sort of how it looks. And again, the symptoms here, it's all the same stuff we're going to be asking about. I wanted to point out the key new feature here on the bottom is a neurologic problem. So folks with non-compaction can be at risk to have blood clots form in those little areas that you see there on the left-hand side of the picture. Blood can get stuck in there and clot, and then if it sort of pumps out of your heart, the blood clot can travel to another part of your body and cause a stroke, a mini stroke, a blood clot somewhere else. So this is something we're specifically more concerned about with non-compaction. Similar symptoms, same things we're worried about in addition to the neurological issues, similar workup, and if you have had a neurological issue with a stroke or mini stroke, we'll include an evaluation of the brain. And then similar sort of cocktail for medicines in the same approach, decreasing the work of the heart, helping the blood flow get to the rest of the body, balancing your fluid, and then if you need to, thin your blood. And this is, again, a decision that we make with each patient depending on how bad your disease is. But I've just listed a couple of medications here you may have heard about that are blood thinners. So folks with non-compaction may be on some of these. And again, similar sort of situation with the abnormal heart rhythms. And then lastly, with arrhythmogenic cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy, what really sort of stands out first is not the heart failure symptoms for us, it's usually the abnormal heart rhythm, so that's what we're most concerned about at the beginning. So we'll really be asking you more about the skipped heartbeats and the palpitations and the dizziness and passing out. We certainly still care about all of the other things like shortness of breath and that, but I just wanted to give you a little bit of sense of the difference. The workup and the evaluation is pretty much the same. And you can see here, this is a video of an MRI of a heart with arrhythmogenic right ventricular cardiomyopathy. We usually say that the left ventricle should look like a donut and the right ventricle should look like a croissant hugging the donut. Yeah, everybody looked up. I'm sorry, this one doesn't look like a croissant. It's a big, boggy croissant on the side of the donut, but that's the right ventricle. You can see it's not really pumping so well. And so again, the treatment process is the same. The evaluation is the same. We start talking about pacemaker, defibrillator, arrhythmia ablation, or medicines targeted to stop the abnormal heart rhythms before we need to get to that point. And we also, of course, keep an eye on the kidney and liver, especially in this situation. And again, these folks can also have disease that is severe that requires thinking about what's the next step. And in this case, we do have patients that go on to heart transplant. And so if you're having symptoms on medicines, your heart pumping is getting weaker, or you're still having abnormal heart rhythms despite doing the defibrillator medicines and the ablations if appropriate, or your kidneys or liver are sort of tipping over, these are sort of all signs that we have to start thinking about the next step. So hopefully I've accomplished this outline. We've talked about each of these different cardiomyopathies, their presentations, how we manage them medically, when sort of thinking about the next steps with device and surgery and timing for transplant. So thank you very much.